This presentation is on behalf of the IDPH Obstetric Hemorrhage Project. I am Kayla Carroll, the perinatal educator in OB, and will be facilitating the implementation of the requirements at FHN. At least 160 million women become pregnant around the world each year. Of these, 15% develop complications related to pregnancy, which lead to the deaths of about 600,000 women. Many of these deaths could have been prevented. In fact, over 10 million women suffer annually from complications that seriously affect their health, often permanently. Postpartum hemorrhage is an unpredictable and rapid cause of maternal death worldwide. Current evidence indicates that with appropriately trained staff and the necessary equipment, there can be a significant reduction in the incidence of hemorrhage. Improving health care for women during childbirth in order to prevent and treat hemorrhage is an essential step towards the achievement of Healthy People 2020 goals. This slide includes the current Hemorrhage Review Committee members. This information is meant to define practices that meet the needs of patients in most circumstances and are not a replacement for clinical judgment. The ultimate decision about care for a particular patient must be made by the healthcare provider and patient in light of the circumstances presented by that patient. This is a typical case that could have happened in any hospital in the United States. In fact, it is an actual case reviewed by the Maternal and Morbidity Review Committee, also known as the MMRC. Specifically, this is a 28-week patient with complete previa who presents with profuse vaginal bleeding. Her admission vital signs are a blood pressure of 109/70, heart rate of 110, and a hematocrit of 22. Immediate C-section is performed under general anesthesia where she lost 750 mLs of blood and received 2,500 mLs in fluid replacement. Her urine output was 200, and post-extubation her heart rate was in the 120s. Subsequently, this patient became alluric and without improvement after several fluid boluses became anuric and went into DIC. She was taken back to the OR with exploratory lap showing no evidence of intraperitoneal hemorrhage. Considering the details provided in this case, what is the most appropriate next step in management of this patient? Is it continued aggressive fluid volume replacement with blood products, urology to consult to assess for concealed GU injury, CT scan of abdomen to look for concealed bleeding, or renal consult to work up her renal disease? The answer in this case is aggressive volume replacement with blood products. It is important to identify the major opportunities in this case. The opportunities include delay in diagnosis, underestimation of the blood loss, and hemorrhage and profound hypovolemia, as well as delay in treatment, inadequate initial resuscitation, irreversible hemorrhagic shock, coagulopathy, and acute tubular necrosis. The time from admission to death was only 21 hours. Hemorrhage is a worldwide problem that can be decreased with appropriate resources. It remains the #1 cause of maternal mortality and the most common form of shock in obstetrical practice. The high number of maternal deaths in some areas of the world reflects inequities in access to health care services and highlights the gap between the rich and the poor. The global maternal mortality ratio has declined by 45%. Although there has been improvement in it, it is not enough. There are still areas like sub-Saharan Africa that have extremely high rates of maternal mortality. In the United States, between 1994 and 2006, overall, we have seen an upward trend in hemorrhage, with the major indicator being uterine atony. It is important to know that hemorrhages can start in the antepartum period. In the United States, hemorrhage has moved down in occurrence but still remains in the top 5 causes of pregnancy-related death. The graph shows percentages of pregnancy-related deaths in the United States in 2011. As you will see, hemorrhage accounted for 11.3%. Maternal deaths due to obstetric hemorrhage came from all levels of care throughout the entire state, including Level 3 hospitals and perinatal centers. The 3-year total from 2006 to 2008 were 11 deaths. Once the program was implemented, there were 5 fewer deaths. But once again, our immediate cause of deaths from hemorrhage is increasing. 2 different topics appear on this slide. The purpose of the left-hand side of the slide looks at deaths by various etiologies and care factors. It is important to note that there are numerous etiologies for hemorrhage in Illinois, and not all hemorrhages occur during the postpartum period. Hidden blood loss is not uncommon. The purpose of the right side of the slide is to demonstrate that the majority of maternal deaths due to blood loss were found to have preventable factors related to patient care. To date, these are the potentially avoidable factors in care that were identified by the MMRC. This educational program will highlight these potentially avoidable factors. Factors include no or inadequate identification of risk factors, delayed or wrong diagnosis, underestimation of blood loss, delayed and or inadequate treatment, inadequate or inappropriate referral, consultation, and transfer of care, inadequate documentation, and chain of communication issues. The purpose of this presentation is to reinforce why we are doing this project. Our goal is to improve risk assessment and preparation, early identification of obstetrical hemorrhage, treatment of hemorrhage and hypovolemia, as well as to create and implement a rapid response team for coordinated management and policies and guidelines for us to follow. No single satisfactory definition of hemorrhage exists, and a number of definitions are currently in use worldwide. While existing definitions allow comparison of rates of hemorrhage, the clinical relevance of these volumes of blood loss in otherwise fit, healthy women is questionable. Many of the deaths in Illinois were missed because of the antepartum blood loss that was not calculated. An international expert panel of obstetrics, gynecology, hematology, transfusion, and anesthesiology undertook a comprehensive review of the literature. In a meeting in November 2011, the panel agreed on a definition of severe postpartum hemorrhage that would identify those women who were at high risk of adverse clinical outcomes. Having a definition helps Illinois look at morbidities and compare data throughout the state. Having a definition that includes a specific amount is meant as a starting point in the evaluation of a hemorrhage. Determination of rates of clinically severe hemorrhage may be more useful. From this, we can determine if the severity of a hemorrhage is influenced by the rate and the total volume of blood loss, and also the response of the treatment. This definition is more of a coding definition, but each hospital must have processes in place to be able to monitor and evaluate cases. The definition included on the slide is also supported by ACOG's Revitalize initiative. The definition of perinatal hemorrhage is persistent, ongoing, active bleeding greater than 1,000 milliliters within the first 24 hours following birth that continues despite the use of initial measures, including first-line uterotonic agents and uterine massage. This slide provides patient history and progress of hemorrhage and another actual case reviewed by the MMRC. The next 3 slides will include questions related to this case. This is a 42-year-old G7 P5014 at 37 weeks gestation with a prior fetal demise, 3 prior C-sections, and known placenta previa, who presents for a repeat C-section due to worsening hypertension. Her admission blood pressure was 186/92, followed by 198/98, and a heart rate of 80. Initial labs included hemoglobin of 14.6, hematocrit of 43.8, and platelets at 190. During the delivery, findings included adhesions, complete placenta previa, and she delivered a viable male infant with an intraoperative blood loss of 700 an intraoperative blood pressure of 140/88. This patient's history of 3 prior cesarean deliveries and a known placenta previa puts her at increased risk for A. Antepartum hemorrhage, B. Placental accreta, C. Ruptured uterus, or D. All of the above. D. All of the above is the correct answer. In addition to her placenta previa, which would be considered a risk factor for perinatal hemorrhage? Choose the best answer. Chronic hypertension, grand multiparity, maternal age, or history of fetal demise. The answer is B, grand multiparity, because it has a direct causal relationship with obstetric hemorrhage. The other high risk factors listed may lead to hemorrhage, example, chronic hypertension, which may lead to abruption, but itself is not directly linked to hemorrhage. What additional laboratory test or test should you consider prior to her repeat C-section? Choose the best answer. A. Type and screen. B. 24-hour urine collection for protein and creatinine clearance. C. Uric acid. Or D. Type and cross match. The answer is D. Type and cross match. In this section, we will discuss the importance of risk assessment and preparation. The most important point to remember is that the plan is always based on the etiology of the hemorrhage. This slide depicts the risk factors associated with perinatal hemorrhage. Other risk factors associated with hemorrhage that are not listed include general anesthesia, history of hemorrhage, prolonged use of oxytocin, transfusion-dependent sickle cell disease, prior uterine surgery, chorioamnionitis, polyhydramnios, and Jehovah's Witnesses have an increased risk of hemorrhage because they may not accept blood products. This slide stresses the importance of developing a plan according to identified risk factors. Additional considerations may need to be taken. Examples include a C-section taking place in the main OR versus labor and deliveries OR, the time of day the case takes place, or staffing considerations that can be planned prior to. Remembering that this is a 42-year-old G7 P5014 at 37 weeks with a prior fetal demise, 3 prior C-sections, and known placenta previa, who presents for a repeat C-section due to worsening chronic hypertension. Please pay close attention to the trending of vital signs from admission through recovery. At what point do you first suspect potential hypovolemia? A. At 18:15, B. At 18:55, C. At 19:03, or D. At 19:20. The answer is A. At 18:15. Always be suspicious if a blood pressure of a hypertensive woman becomes normal. The following slides focus on recognition, visualization, and quantification of blood loss. The blood loss at a vaginal delivery is given 350 milliliters. To quantify this amount correctly, the blood volume in the collection drape should fill A. A standard soda can, B. Half gallon of milk, C. Pint of milk, or D. Quart of milk. The answer is A. A standard soda can holds approximately 350 milliliters. The purpose of this slide is to identify that one can recognize blood loss in an emergent situation by visualizing familiar objects to estimate the loss. This should only be done until a scale is available. Note that the only accurate method of quantifying blood loss is weighing. Remember, 1 gram equals 1 milliliter. Additionally, each unit of packed red blood cells contains approximately 200 milliliters of red cells, and in an adult will raise the hematocrit roughly 3 to 4 percentage points unless there is continued bleeding. Continuing with case 2. The first fluid bolus ordered at this time was 500 mLs. Is this amount adequate? Adequate if vitals were checked Q5 minutes and bleeding slows. adequate if blood replacement is ordered, or inadequate? The answer is D. Fluid replacement should be followed by the guideline of 3 mL of replacement to 1 mL of blood loss. In this example, if one orange-sized clot is 250 mL, then 3 would be 750 mL. Fluid replacement needs to be 3 times that, so with that being said, a 500 mL fluid bolus is inadequate. Once again, remember blood loss must be quantified by weighing or measuring as soon as equipment becomes available. Visual estimation is not a reliable predictor of blood loss and should only be used until equipment is available in emergency situations. Here at FHN on the hemorrhage cart is the dry weight of individual supplies such as pads, laps, etc. By subtracting the dry weight from the soiled weight, you will get the most accurate method of calculating the blood loss. A standard 18 by 18 lap that is 75% saturated with blood represents a blood loss of A. 25 mL, B. 50 mL, C. 75 mL, or D. 100 mL. The correct answer is B. 50 mL. It is imperative that blood loss is assessed and measured as accurately as possible. Always remember that 1 gram of blood equals 1 mL of blood. This slide is an example of quantifying blood loss. We will have the opportunity to practice doing this as well during our simulation lab. Quantification of blood loss has been shown to decrease the incidence of errors in blood loss estimation. For that reason, IDPH is requesting weighing and measuring contents for accuracy. Blood loss estimation can lead to overestimation, which leads to unnecessary treatments, or underestimation, which leads to delay in treatments. When quantifying blood loss for vaginal delivery, keep in mind that most of the fluid collected prior to birth of the placenta is amniotic fluid, urine, and feces. For a C-section delivery of the placenta, measure the amount of blood lost in the suction container and drapes. At this point, most of the blood will be accounted for. As a side note, Brace and Wolf studied amniotic fluid volumes throughout pregnancy and came up with norms. For birth without prior rupture of membranes, the following volumes can be used for approximate amniotic fluid volumes at term. Normal fluid volume being considered at 700 mL, oligohydramnios or low fluid volumes at 300 mL, or polyhydramnios, excess fluid volumes at 1400 mL. This is a tool that California developed to quantify blood loss for cesarean sections, which includes suctioned blood, lap sponges, and other measured loss. Remember, quantification of blood loss is the state of Illinois standard. This chart is a reference that combines blood loss classification and replacement parameters. Severity of bleeding is gauged by combining both actual weight in grams and clinical signs related to hypovolemia and hemorrhage. An insidious feature of hemorrhage is the failure of the pulse and blood pressure to undergo more than moderate alterations until large amounts of blood have been lost. The maternal response to blood loss depends on the magnitude of pregnancy, such as induced hypervolemia, the amount of volume lost, and internal adaptive mechanisms. An important point to note is the normotensive woman may actually become somewhat hypertensive in response to hemorrhage, at least initially. A hypertensive woman with blood loss may become normotensive because she is hypovolemic. Ultimately, the hypovolemia may not be recognized until very late. For fluid replacement, abiding by the 3-to-1 rule, the maximum volume of infused clear fluids should ideally not exceed a total of 3.5 liters. Blood loss can occur at any time in the perinatal period. The goal is to assess blood loss and compare it to the clinical signs of hypovolemia. Causes of obstetric hemorrhage associated with an intrauterine gestation include but are not limited to placental abruption or previa, uterine rupture, surgical laceration, invasive placentation, and uterine inversion. The causes of postpartum hemorrhage can be classified into four main groups: uterine atony, placental issues, genital tract trauma, or systemic medical conditions. Remember that the two processes often occur simultaneously are hemorrhage and hypovolemia. At times, blood loss may be concealed and may have occurred prior to admission, so it is important to identify signs and symptoms of hypovolemia in addition to the quantifying of blood loss. To emphasize that the early signs of hypovolemia are often missed, choose the earliest sign of compensatory change that occurs with hypovolemia. A. Tachycardia, B. Hypotension, C. Hyperventilation, or D. Pallor. The correct answer is A. Tachycardia. If you answered B, please know that hypotension is actually a late sign of hypovolemia. Initially, providers may use visual estimation when evaluating blood loss. However, following vital sign trends is imperative for the recognition of hypovolemia. The question to then ask is, does the visual estimate of blood loss correlate with the vital signs? As soon as possible, weighing should be done to quantify the blood loss. Providers should not wait for major shifts in blood pressure to intervene. Blood pressure is the last vital sign to change because of vasoconstriction. Monitor trends. Again, hypertensive patients may become normotensive when hypovolemic. Monitor hypotensive patients more closely. Now let us look at the physiological changes. Approximately 30% blood loss accounts for 1,500 to 2,000 mLs. For pulse, the pulse rate actually increases after around 15 to 20% blood volume lost. Tachypnea is actually an early sign, partially driven initially by anxiety. As the respiratory rate increases with progressive blood loss, respirations will usually exceed 20 when 30% of the blood volume is lost. Pallor. Oxygenation becomes harder to assess clinically as peripheral pallor becomes more marked, and the pulse ox becomes less reliable as peripheral perfusion becomes weaker. Change in mental status. The early stages of shock are associated with restlessness and agitation, sometimes with a heightened sense of thirst, but these progress to drowsiness when around 30% of the blood volume is lost. Loss of consciousness is a very late sign with significant risk of imminent death. Capillary refill is slowed after 15% of blood volume is lost and is also completely absent when 40% of the volume is lost. In the cases of severe hemorrhage, the minimum rate of urine output per hour needed to prevent renal tubular necrosis is A. 10 milliliters per hour, B. 30 milliliters per hour, C. 100 milliliters per hour, or D. 300 milliliters per hour. The answer is B. 30 milliliters per hour. In cases of hypovolemia, blood is shunted away from the kidneys, increasing the risk of tubular necrosis. It is very easy for there to be a delayed recognition of hypovolemia in pregnancy due to maternal physiology. During pregnancy, women are actually in a hypervolemic state. Their blood volume increases by nearly 50%. For example, a 130-pound pregnant woman has a blood volume of 6,000 mLs at 30 weeks gestation. However, due to the physiology, approximately 30% of the blood volume is lost before vital signs are altered. Please note that hypovolemia is a clinical condition characterized by inadequate tissue perfusion from impaired peripheral circulation because of diminished intravascular blood volume. As I stated before, blood pressure is the last vital sign to change and is due to systemic vascular resistance and cardiac output. This is due to catecholamine being released during a hemorrhage, which causes generalized increase in venular tone, resulting in an autotransfusion from this capacitance reservoir. These changes are accompanied by compensatory increases in heart rate, systemic and pulmonary vascular resistance, and myocardial contractility. Let's wrap up and summarize Case 2. As you'll notice on the slide, 4 hours postpartum, this patient's urine output was 20 mLs per hour. She was given 1 liter of D5-LR over 2 hours, and her hemoglobin resulted at 5.9. Then, 12 hours postpartum, she received her first unit of packed red blood cells. Her blood pressure was 90/50 with her pulse 128. The patient was combative. She was oozing blood at her IV site. A pelvic exam resulted in 2 5-centimeter clots. An additional estimated blood loss accounted for 1,600 mLs, and the patient coded 5 minutes after the pelvic exam, and despite resuscitative attempts, the patient expired. Please remember, as I stated before, this was a real case. Due to the adverse outcomes of this case, it went to the MMRC to be reviewed, where issues were identified that contributed to the death of this patient. As you see in the slide, the issues identified were no or inadequate identification of risk factors, delayed or wrong diagnosis, underestimation of blood loss in the OR and postpartum, and delayed or inadequate treatment. Lack of documentation has been identified as a major problem during hemorrhages. Lack of documentation places both the patient and the staff at risk. Documentation must include date and time and name of provider for each person who provides care during the event, ongoing vital signs, signs of hypovolemia, actual blood loss found through quantification, interventions, patient response, and who the above information was reported to, and lastly, any discussion with family members along the way. Now we will discuss treatment and product replacement. This slide highlights that blood loss can occur at any time in the perinatal period and that 2 processes are going on simultaneously. Blood loss can be concealed or avert, and interventions must be directed at correcting hypovolemia while simultaneously treating the etiology of the hemorrhage. Once blood loss is recognized, the underlying cause of the bleeding and the hypovolemia must be treated. Once a significant hemorrhage has been identified, it is imperative to activate a chain of actions to assess the situation and to treat the bleeding and the hypovolemia. The first step is to communicate. Get help. It is not feasible to do all necessary actions alone. The situation may require another provider or the rapid response team. Simultaneously, the following steps need to occur. Identify the source of bleeding and perform resuscitative measures. Identify ways to stop the bleeding, and continue to monitor aspects such as vital signs, bleeding, and lab results. The acronym ORDER is used in ACOG's Technical Bulletin 235 to help providers remember the actions from the previous slide in a logical manner. In this slide, you will notice the D is most appropriate for a postpartum hemorrhage. After a normal spontaneous vaginal delivery, bright red bleeding continues in the presence of a firmly contracted uterus. This is likely the result of A. Uterine rupture, B. Retained placenta, C. Vaginal laceration, or D. Thrombocytopenia. The correct answer is C. Vaginal laceration. Uterine atony is the most common cause of primary postpartum hemorrhage. IDPH recommends active management of the 3rd stage of labor. Active management of the 3rd stage of labor consists of interventions designed to speed the delivery of placenta by increasing uterine contractions and to prevent postpartum hemorrhage by averting uterine atony. More specifically, the 3rd stage of labor consists of the time that elapses from birth of the baby until expulsion of the placenta. It can be summarized in 3 distinct parts: placental separation, placenta expulsion into the vaginal vault, and actual expulsion of the placenta. Physiologically, the placenta separates from the uterine wall because of capillary hemorrhage after the umbilical cord stops pulsating. This is facilitated by the mechanical action caused by uterine contractions. Hemostasis is achieved by contractions and the retraction of the myometrium. To actively manage the 3rd stage of labor, administer uterotonic medications to stimulate uterine contractions, while meanwhile applying controlled traction to the umbilical cord while applying simultaneous counterpressure to the uterus through the abdomen while delivering the placenta. IDPH recommends using a standardized protocol for the third stage of labor management. The American College of Obstetricians and Gynecologists, also known as ACOG, along with other experts, recommends the administration of uterotonic agents during the third stage of labor and immediate postpartum period to prevent uterine atony and accompanying hemorrhage. Unfortunately, oxytocin can be associated with serious side effects including tachycardia, hypotension, myocardial ischemia, and even death, especially in hypovolemic or other hemodynamically compromised women. Many of these adverse effects follow dose-response kinetics. The dose of oxytocin required to produce uterine contractions postpartum is much lower than previously thought. In addition, bolus dosing of oxytocin followed by infusion is not more effective than intravenous infusion alone and is no longer recommended. This slide shows an example of a standardized oxytocin postpartum protocol that is used in many Illinois hospitals and is recommended by IDPH. Based on the increased awareness of the dangers of administration of high-dose oxytocin and the dose-response data, experts have advised practitioners to devise rational, evidence-based protocols governing the use of oxytocin during the third stage of labor and postpartum period. As you will see, a standardized premixed concentration of oxytocin should be used via an infusion pump. Administer the standardized rate immediately after the delivery of the fetus. For the first hour, the rate should be 300 milliliters per hour, followed by a second hour at 60 milliliters per hour. If uterine atony is present, the rate can be increased to 600 milliliters per hour for 1 hour. After an hour and bleeding subsides, the rate can be decreased to 60 milliliters per hour. If the patient does not have an IV access, administer 10 units of oxytocin IM and start an IV to run oxytocin in at 60 milliliters per hour until the fundus is firm or the patient's recovery has ended. Always be aware of your patient's risk for hemorrhage. Key pieces to note are the importance of sequentially administering uterotonic meds and documenting each time you administer a medication. Empty the bladder to maintain uterine tone, massage the uterus, and ensure that your IV site is maintained. Always remember that hemorrhage and hypovolemia often occur simultaneously. At times, blood loss may be concealed or may have occurred prior to admission. It is important to identify signs and symptoms of hypovolemia in addition to quantifying blood loss. Hematomas are an example of concealed blood loss and should be considered when a patient reports pain and pressure that seem disproportionate to her delivery. When uterine atony is diagnosed and bleeding persists despite treatment with uterotonic drugs and other conservative interventions, surgical intervention should be used without further delay. Some non-surgical interventions include fundal massage, bimanual uterine compression, uterotonic medications, and tamponade devices such as the Bakri balloon. There are also other measures that may be appropriate if a chance of hemorrhage is suspected prior to delivery. TXA is available at FHN. It is an antifibrinolytic agent that inhibits clot breakdown by blocking the lysine binding sites on plasminogen molecules. TXA is not a new drug and has been used for many years for treatment of menorrhagia and dental extraction in people with hemophilia. More recently, it has been used to reduce bleeding in electrosurgical patients. Although there are many ongoing trials of TXA in elective surgery, the accumulated evidence already shows that TXA reduces bleeding. This slide includes the medications that are considered the first line of treatment in hemorrhage. Oxytocin or Pitocin can be used via the IV, IM, or intrauterine route. It is important to note that Pitocin must be diluted in a crystalloid solution in order to be used via the IV route. Methergin is also available via the IM or PO route. It is important not to give Methergin to a hypertensive patient. Hemabate is available IM or intrauterine. It is important not to give Hemabate to an asthmatic patient. Also, Cytotec. Cytotec is available sublingual, PO, or rectal. These medications, their dosing, and special considerations are included on the hemorrhage cart. This slide speaks to the method of testing the efficacy of blood coagulation. TEG is a method of testing the efficacy of blood coagulation. More common tests of blood coagulation include PT, INR, and PTT, which measure coagulation factor function. It is important to assess a woman's stance towards blood products well in advance of labor or planned surgery. After personal discussion, some women may be willing to accept some blood products, such as fresh frozen plasma, erythropoietin, cell saver reinfusion, and even some will accept red cells in the face of death. The goal during the conversation is to find common ground to manage the birth as safely as possible, build trust, or if not possible, to transfer the patient to a program amended with the plans, develop a well thought out delivery plan to minimize blood loss and maximize decisive decisions. Prenatal optimization of hemoglobin and developing a detailed management plan for delivery are critical steps for women who may decline transfusion for some or all blood products. The general principles of bloodless medical management include employing a multidisciplinary treatment approach to blood conservation, formulating a plan of care for avoiding or controlling blood loss, consulting promptly with senior specialists experienced in blood conservation, promptly investigating and treating anemia, being prepared to modify routine practice when appropriate, restricting blood draws and lab tests until absolutely needed, decreasing or avoiding the use of anticoagulants and antiplatelet agents, stimulating erythropoiesis, and ultimately transferring a stabilized patient, if necessary, to a major center before the patient's condition deteriorates. In prenatal care, a comprehensive discussion with a checklist specifying acceptable interventions is suggested. Anemia should be aggressively prevented and consult should be made. In labor and delivery, early anesthesia and pediatric consult is recommended. Reassessment of hemorrhage risk and discussion of options should be ongoing. Review specific techniques, review the plan with the patient and family member, and be decisive. During the postpartum period, maintain volume with crystalloids and blood substitutes, and continue to aggressively manage anemia. Jehovah's Witnesses follows the most basic tenets of the Christian faith overall, with a few unique perspectives. One that directly impacts the care of women in childbirth is the prohibition against receiving blood. Both the Old Testament and the New Testament speak against receiving blood. For Jehovah's Witnesses, this extends to taking blood products into one's body through the veins. According to practicing Jehovah's Witnesses, it is believed that when they give their life without violating God's law, they shall be rewarded with eternal life. Violating this precept is said to lead to excommunication and damnation. Jehovah's Witnesses may not accept transfusion of blood components, including whole blood, red blood cell concentrates, white blood cells, plasma, and platelets, but may make a decision to accept fractions of red cells, white cells, plasma, and/or platelets. Which of the following techniques may be attempted to stop uterine bleeding from the implantation site of a placenta previa during cesarean delivery? A. Bilateral internal iliac artery embolization. B. Bilateral uterine artery ligation. C. Intraoperative uterine packing. Or D. All of the above. The answer is D. All of the above. This slide includes surgical interventions for uterine atony. These interventions are not appropriate in all settings. The decision to use surgical intervention should be made jointly by the rapid response team and obstetrics, taking into consideration the underlying cause of bleeding and the patient's current condition. While nursing staff may not make management decisions, it is important for nurses to be aware of the surgical options and the sequence in which they are most often performed. Examples of surgical intervention include uterine curettage, Beeline suture, uterine artery ligation or iliac artery ligation, uterine artery embolization, or hysterectomy. Hysterectomy is the best immediate option to save the hemorrhaging woman's life when uterine atony is unresponsive to uterotonics in facilities where embolization is not available and or the obstetrician is not well versed in the technical aspects of conservative surgical procedures or iliac artery ligation. This slide speaks to the classification of topical and internal hemostatic agents that can be used during a C-section. There are 4 categories of internal hemostatic products. The 4 categories include mechanical hemostatic products such as gel foam, flowable hemostatic products such as Surgiflow, fibrin sealants, and active hemostatics. This slide is in relation to the first randomized control study of TXA. The study concluded that high-dose TXA can reduce blood loss and maternal morbidity in postpartum hemorrhage. This is the TXA protocol that was used in the study. This protocol is run over 6 hours if needed. It is important to note that at any time, if there is uncontrolled bleeding, early rescue resources should be initiated. Specific roles and responsibilities of staff members during an emergency will be discussed at the simulation. Focus is placed on the importance of getting a second IV line and possible use of the rapid transfuser if appropriate. The acronym ORDER is used to help providers remember the actions in a logical order. Always remember to call for help. Oxygenate the patient with a non-rebreather mask, restore circulation, initiate drug therapy, and evaluate status, including vital signs and oxygen saturations, recording cumulative blood loss, placing a Foley catheter to assess urinary output, and avoid hypothermia using a bear hugger, warm fluids, or warm blankets. Always be proactive in anticipating the next steps that could potentially need to take place. In May 2007, each hospital completed a hemorrhage preparedness assessment, which evaluated the following internal resources: lab test availability and turnaround time, blood product availability and response time from order to transfusion, and personnel availability and response time. The 2 goals of the rapid response team are to treat hypovolemia and determine and treat the etiology of hemorrhage. Treatment algorithms will address how to manage the lethal triad. The lethal triad is recognized as playing a major role in the morbidity and mortality of severely injured or bleeding patients. Components of this triad consist of hypothermia, acidosis, and coagulopathy. This flowchart is from the California Maternal Quality Care Collaborative. It depicts which intervention should be used at what stage of blood loss. This is another example of a treatment algorithm for postpartum hemorrhage. However, this one focuses more on correcting coagulopathy. The purpose of this slide is to help to identify a logical and orderly method of notifying staff in the event of a hemorrhage. The management algorithm summarizes 4 points, including maternal physiologic responses per volume of blood lost, labs to evaluate maternal status, blood replacement products or institution of the massive transfusion protocol, and interventions which can lead to abate the blood loss. A laminated copy of this chart is included in the hemorrhage cart and in the OR for reference. The blood product administration chart reviews the types of blood products, why they are given, and special considerations around each of them. Please note that with acute blood loss, the hematocrit will not change significantly for up to 4 hours. Remember that the infusion of IV fluids can cause the hematocrit to drop before 4 hours. A hematocrit should be obtained if a hemorrhage is suspected, and if a significant drop is seen, assume a large amount of blood has been lost. The American Association of Blood Bank statement recommends adhering to a restrictive transfusion strategy in hospitalized, stable patients. It states transfusion should be given for symptoms of anemia and should not be based on hemoglobin concentration alone. Optimal use should maximize clinical outcomes while avoiding potential risks. According to a research article, active management of the third stage of labor can decrease the number of women experiencing both severe postpartum hemorrhage of greater than 1,000 milliliters of blood loss and anemia, defined as a maternal hemoglobin less than 9 after delivery. Rapid restoration is essential for ensuring adequate tissue perfusion and preventing acidosis, coagulopathy, and hypothermia. Massive transfusion protocols vary considerably from institution to institution, and no internationally accepted protocol exists. The goal of FHN's protocol is to produce an algorithmic, proactive, ratio-based approach to facilitate timely blood product release and mitigate blood bank delays. Please take a moment to become more familiar with the massive transfusion protocol at FHN. To continue with massive transfusion, regardless of which substance is selected for volume expansion at the stat of a hemorrhage, it is essential that blood be administered and that a protocol be available for the issue of blood products. The fluid replacement strategy consists of crystalloid and colloid solutions replacing the loss of intravascular volume, red blood cells restoring oxygen carrying capacity, and clotting factors and platelets restoring physiologic hemostasis. A colloid is defined as a high molecular weight substance that largely remains in the intravascular compartment. Colloids are considered to have a greater intravascular persistence when compared to crystalloids. Examples of colloid solutions include hetastarch, albumin, and hypertonic saline. The degree of volume expansion is mainly determined by the molecular weight, whereas the intravascular persistence is determined by the elimination of the colloid. When compared to crystalloids, colloids induce a greater plasma volume expansion for the same administered volume. This is another example of a massive transfusion protocol. It stresses the importance of early administration of products. At FHN, our massive transfusion cycle pack consists of 4 units of packed red blood cells and 4 units of fresh frozen plasma. Be sure to communicate an anticipated need for platelets in the event of a hemorrhage. Now to conclude with a summary of the IDPH hemorrhage project. As you remember, this presentation has been broken into 4 main steps to managing hemorrhage to decrease the risk in Illinois hospitals. These steps include preparation and risk assessment, recognition, treatment, communication, and quality reporting. Step 1. Preparation and risk assessment. Risk assessment occurs on every patient at the time of admission. It is imperative to communicate the findings of this assessment to the team. Staff preparation is essential. For example, do you know where the hemorrhage cart is located? Do you know how to retrieve hemorrhage medications? Remember, at times blood loss may be concealed or may have occurred prior to admission. It is important to identify signs and symptoms of hypovolemia in addition to using quantification of blood loss, as well as trending vital signs. The key to management of a hemorrhage is to recognize excessive bleeding before it becomes life-threatening, identifying the cause, and initiating appropriate interventions. We have discussed many possible effective interventions and algorithms throughout this presentation. Step 3 is treatment of hemorrhage. The goal is to quantify blood loss, correct the hypovolemia, and find and treat the cause. Step 4 is communication strategies. Debriefing and the documentation of a debrief is important but very easy to overlook. Debrief is usually done soon after the event. During this time, individuals should discuss what went well and possible learning opportunities. This is a perfect time to make sure everyone is documenting the correct time of events as well. Communication strategies continued. A hemorrhage event requires that communicators be organized in thought and concise in communication. S-bar provides distinct clarity regarding the situation to the provider, who may have to prioritize multiple demands and/or request assistance from another provider. Provide a statement related to pertinent history and what got us to this point. Summarize the facts and give your best assessment. What's going on, and be sure to always use your judgment. Lastly, what actions are you asking for? What do you want to happen next? Never be afraid to use the term "I am concerned" in your communication. The key steps for reducing maternal mortality and morbidity due to hemorrhage include training of all healthcare providers in early diagnosis, prevention, and treatment, promoting and reinforcing the value and effectiveness of active management of the third stage of labor, developing and using treatment protocols, monitoring the incidence of hemorrhage, and ensuring quality assurance. Step 5 is the quality reporting and systems learning. Please note that IDPH requires all hemorrhages receiving 4 units or more of blood products and/or ICU admissions must be reported to the perinatal center. Quality reporting and systems learning continued. This is a recommended process for obstetric hemorrhage quality reporting. It is important that the quality reporting includes debriefing of all hemorrhages with all involved members. Furthermore, these cases are reported to the perinatal center and reviewed at M&Ms, where outcomes are shared and discussed amongst the multidisciplinary team. This concludes the didactic portion of the IDPH Hemorrhage Project. Thank you for your time and attention. Please contact me with any questions or concerns, as I am happy to help.